Dr. Angela Zambrano from Colombia.
Nuevo para
So I'm
tiempo.
going to just introduce you to her before she goes on. So Angela Zambrano is a medical oncologist from Colombia, interested in the field of gastrointestinal cancer and cancer in minorities. Also interested in cancer prevention and early detection of cancer. Currently,
Wow.
her team is conducting studies with indigenous communities to deepen the knowledge of their cultural aspects and worldviews of cancer, to design and implement programs involving their representatives in developing strategies to reduce the gap in prevention and the prevention and prevent sorry in prevention so improve in prevention and early detection of cancer.
No, no, palabra.
In addition, they're also developing activities that encourage research and specialist training in the areas of oncology in Latin America. So we're very delighted to have Dr. Zambrano with us, and I give you the mic to do your presentation. Thank you.
Good morning. Thank you so much. Can you hear me?
Yes, we
Sorry.
can hear you.
Sorry. Can you see my screen?
Yes, we see your screen.
Okay. Thank you. It's a pleasure for me to be here, and it's a really honor to share with you our job. This is a study about indigenous population in Colombia, that is particularly Pijao communities. And this is the first study for a long term, that around more than 20 years, it's around 26 years. So this is a really pleasure. Let's see. No puedo seguir. Okay, sí. Sorry. Before all, we know that the indigenous communities around the world is they have a big back situation because they experience a disproportionate cancer burden. So that's related like light stage diagnosis, reduces survival, and higher incidence. That's not Colombia is not the exception for that. So among the top 5 of cancer, the top 5 disease of cancer death of cancer causes death is cancer for so it's around four place. Yes. The systematic cancer data for a specific indigenous group is remain several limited. We don't have access to data for this community. So this is the first study, like I told you about this. So our objective was characterize cancer incidence for this population, as told you, using this data from insurance that they have in the record insurance. So as I told you about the methods, we have the first is the study design is a retrospective open cohort study. And the location is basically in Tolima. Tolima is a department that is located in the southwest in Colombia. This particular population is located also in another departments like Risaralda and Meta. But in Tolima, we have the majority population that is around more than 80% of this population. In this study, we see that the population is more than 100,000 for the health provider, that is the name in Colombia is IPSI. It's around more than 100,000 affiliates that is correlated with 42,000 indigenous Pijaos that qualify for criteria, including inclusion criteria that was more than 8 years and older, that they have to follow at least for 6 months, and no previous cancer diagnosis. Also, if we adjust this population, we have to explain after this, but I have to say that we have 365,000 person years when we adjust with giants. The sources for this population is come from the high cost disease registry, these medical records, and also from the pathology reports. And I have to say that we have to take an account the ICD code 10 code codification and just the first primary cancer only. Around the statistical analysis, when we measure the age standardized incidence, we take an account for reference population that they have registered, mature registered in the world. So that's such as we have to take an account the WHO, the SEGI, the European, and the Maori registry. Also, we have correction by the Chiams and the Lexis diagram. And here we have a flow diagram that then we can see at the right how we select the population for this study. So we have the first, the population from the top population registry according to the population that is around more than 100,000. And finally, we have the population that is around more than 4,000, that is basically 42,000. And then we have 142 cases. So at the left, we have the key numbers that I want that you have in mind. That is the total affiliates for this insurance that we have is more than 100,000 affiliates. The indigenous people, specifically Pijao people, that is more than 4,000. And at the end, we have just 142 incidence cancers. And I know, and we know that is a small number, but we have to explain why probably we have a small number for this population here. And the population pyramid, we have this is a structure. So at the left, you can see the male that is in yellow, and in purple at the right, we have female women. And then I say that the median age for this population is 35 years. That you can see that is very young population, and more than 50% were female. The total population, as we know, that is more than 100,000. That is important because when we have to, that's the reason why we have to take an account for mature registry or population, because our population is very, very young. So here in the overall cancer incidence, as we know, we have 142 incidence cancer. The growth rate was 38.9 adjusted, and women we have around 59%. So here this is very important that we have in the part of this slide. We have the reference standards. So we have the Maori indigenous standard that you know that are located in New Zealand. The age standardized rate was 27, and then we see the European standard was 44 per 100,000 people. So if we take an account just a European standard, we can overestimate, as I told you here in a slide, and it's probably is not appropriate for young cohort like us population. So this is indigenous population. So here the best match is Maori indigenous standard. So that's the population that we compare. And I told about cancer by anatomical site. We see that the skin is a very important, that is a big number here, and is a little and is a little different that we see in a with a when we compare with another indigenous population around the world, like New Zealand or US or inclusion or in Canada, because the skin cancer is very small, and is no melanoma skin cancer. Yes, I have to clarify this because it's no melanoma. And if we see cervix, stomach, prostate, and breast, for this population is very low if we compare with another indigenous population. So here we have breast 3.8 compared with another population that is 60 to 80 per 100,000, and cervix is similar to 2.5, and the prostate is also very low for this population. And then probably this characterization probably reflects that the really situation that is happening is probably because it's under diagnosis. Is more probably for this situation. They have a lot of geographic barriers in this territory. About temporal dynamics, and also this is important. Why? Because when we see this 26 follow-up 26 years, we see that is we see 2008 and 2017 that they increase in 80%. We have to make a question: is real that is increasing? This epidemiological increasing. So then we see that for this period of time, we have some situation that happened that probably affected this increasing. So like health resolution, we have for Colombia 2 health resolution in this period of time, one in 2010 and the other in 2014. This resolution is say that it's mandatory to describe to report in the high cost disease surveillance. And also situation was the electronic medical record implementation, and also was the enhanced diagnosis infrastructure. So this factor we have to take an account when we have to talk about the increasing of this is for this period of time. About geographic distribution, that is also a situation. And so here, and I told you, we have three departments, the Tolima, Risaralda, and Meta, but we have just focused in Tolima because they concentrated this population at more than 80%. So we have four. Ibagué is a capital city from this department. They have 21% of total of the cases. It's around 30 cases. And as we compare with crude rate for Mauri, if we compare with Mauri, a standard rate is very low. And Tolima Department, as I told you, they have more than 80% of total of cases. And also is that we have to make a question, is real this situation? And it's probably no, because this is the referral center. And they usually that happen for these departments, they usually refer the patients to the referral center, like Ibagué. So they have, Ibagué represents more patients, but it's usually just for because they have more referral patients. Also, six municipalities present zero cases, and that's probably does no that is they don't have they have small cases, but it's also here we have an geographic barrier that they have a long distance, and the reference center is located in more than 8 hours driving. And now the discussion we have to take an account for main issues we have here. First, the skin cancer. As you know, we see that the skin cancer is the main malignancy that is presenting here. And it's probably because usually the people that live in this place, in this area, they have agricultural activities, and they exposure for a long time for UV exposure. Also, cervical and gastric cancer. As I show you, we have a small numbers, 2.5 per to 100,000. For example, for cervical. So that reflects screen gaps. We have, with this population, we have a big issue that they have a low percentage of, they don't accept HPV vaccines. And also, we talk about gastric cancer, we have 2.4 per 100,000. And it's related like with H. pylori, that usually happen with another part of the population or indigenous population around the world. On the diagnosis that happens when we see breast and cervical cancer, and that the number here for this population are very low when we compare with another indigenous population in another part of the world, like in New Zealand or Canada or US. And it's probably because they have more quality data because they have mature registry. For Colombia is the first, as I told you in the previous slides, is the first long-term design study about the indigenous community, like Pijao. And temporal increasing, as we see in the previous slides, that is reflecting increasing of cases, is we need to see very to in these very um, we have to see that they have different reforms, health reforms, administrative reforms that they can reflect that these number are increasing, and is probably is no real. That is, they have to improve it, that the more high that they really happen. Um, for strengths and limitations for this study, we have a strength that is the first longitudinal study for more than 20 years. It's around 26 years. The source of data that is from the insurance that cover a near universal population for this part of the Pijao communities. They take an account, and there is alliance with IARC, systematic case report. And then also we have take an account for reference population around that usually people use in these studies. About limitations, that the source is from administrative records, and this is important. The 76% unspecified morphology, and then we don't have, is that another issue, that we don't have a good quality for pathology report for this part of this health insurance. No individual level risk factor data, and referral bias according with that we see from referral center like Ibagué. But in conclusion, this is the first comprehensive cancer assessment in the Pijao communities. This 26 years that revealed this study revealed that we have how the surveillance capacity can shape that we can observe about cancer burden. So that's is probably the main messages for these studies. This situation that surveillance and how we can observe this cancer, they can affect cancer burden. It's important for this limitation and strengthen that they can help to propose some policy implications and next steps. That is, of course, the formal cancer registry that probably that they have to include ethnicity variables in for these registries. Also, the skin cancer prevention, and here, and we want to say that we propose a brigade last year for this community about this cancer prevention, skin cancer prevention, and also strengthen.
Sorry, Dr. Zambrano, just in interest of time, if it's possible to wrap up the
Okay,
presentation.
okay, thanks. This is the last slide, sorry. And also the cervical cancer control. And then we have to see that we have to promote the HPV vaccines and decentralization for the diagnosis and improving the infrastructure for these areas in the country. Thank you so much. I'm welcome for questions. Thanks.
Right. Thank you very much, Dr. Zambrano. Very much insightful, and we learned. I think I learned quite a bit from this. Not forgetting, us ourselves in the Caribbean, we do have our own indigenous populations in Dominica, and also I'm sure elsewhere in the world they're facing similar challenges. So I have a question, Dr. Zambrano. I would like to know, so you represented in your slides that there are approximately 106,000 P House people living in Colombia, from which you drew your sample. I mean, I'm just curious to find out. I would like to know, um, do all of these P House people live in the same general area? Because I understood they were a minority in Colombia, and I think the number seemed like a lot, 106,000. So are they all concentrated in the same place, or are they dispersed all around Colombia?
Okay, thank you so much, Dr. Evian, for this question. This population usually are more concentrated in Tolima. In this, around 80% of the population are concentrated this, and the other percentage 10 to 15% are concentrated in another department that is Meta and Risaralda, but the majority population is concentrated in Tolima.
Thank you very much. So unfortunately, like we cannot take any more questions, but I really appreciate your time and your presentation and to showing us some of what's happening in Colombia.